What's happening? My
Hey, Doc.
apologies. What's going on?
How are you?
I'm good. How you doing?
I'm good.
Yeah, I dozed off. Was tired.
Uh-oh. Tired.
Yeah, I get tired sometimes.
I'm
Sometimes
sure you
it just
do.
catch up
Not
to me.
sometimes.
Yeah, apologies to everybody that was waiting on us, but I'm here. Let's go. Let's get it.
All right. Yeah, we'll let them join. We'll let them join.
All right. How you
Trickle
been, though?
in.
How you been?
I've been pretty good. I can't complain.
That's what's up. You need to,
Life's been good.
life's been good. Just waiting on things to happen. So
All
somebody said,
right.
what's the topic of the discussion tonight? Everything.
Right, everything.
Whatever y'all want to talk about.
Whatever y'all want to talk about. So if you're just joining, welcome back. If you've been here before, if it's your first time, welcome to Visit DocP with me. I'm Cola Red Bell. I actually was I am one of Dr. Johnson's patients, but I'm
about to say you deserted me now?
I know, right? No, I'm not. But I'm post-op from surgery. I had treatment for fibroids. And we've been doing this, 6 months now? About 6 months now. So we meet once a month and we go live, and people channel a lot of health questions through me and my DMs for privacy reasons. We're not trying to keep you from going to the doctor, but sometimes you may need a little guidance before you have that one-on-one visit. So if you have questions tonight, do me a favor and put them in the question box. At the bottom of the chat, you'll see a question bubble with a question mark. Please put them in there because that allows us to keep track of everything. If I don't get to your question tonight, I do screenshot at the end and I save them and roll them over to the next month. I see people in the chat saying, what's the topics tonight? So we got a lot. We got birth control tonight. We got fibroids, the favorite topic. I got a man's health question. I got a sexual health question. We got a lot. But so we just gonna go ahead and jump right into it. All right, so Doc P, the people say that I don't be getting up in your business enough. We've been doing this 6 months now. So they need to know something about you and not just all this health stuff. We're gonna get to that. But I got a personal question for you. You down for that tonight?
Let's go. Let's get it.
All right, so one person wants to know, they said, you take care of so many people. What do you do for fun to take care of yourself?
So fun to take care of myself is a daily thing for me. Like I'm all about like just physical fitness and diet. So I'm a food nut. So like I don't eat out a ton. So like I cook a ton. I always have my food with me. So I'm always taking care of myself. Like my diet is always on point. And I work out at least 4 to 5 days a week, typically. I mean, unless it gets like horrible for me. I do jujitsu. Jujitsu has really been an outlet for me. I enjoy it. It's almost like it's like chess, if you will. It's consistent thinking. But I like to travel. So typically, my really like tough periods of my life are usually during the winter time. So like fall, winter, I'm like working my ass off. And then when the spring and the summer come, I'm out. So I mean, y'all will see me like traveling up some stuff like over the next few months. Like I don't do as much. I work, but I try to enjoy life a little bit more during the spring and summertime. Travel, actually get outside and do stuff. Get out with my kids. My kids both play sports. They're in high school, so I enjoy watching them grow. Their last few years of adolescence before they out of the nest. So that's pretty much, those are the biggest things I do. I work hard, but I try to enjoy myself as well.
Hey, Kristen. All right. Well, that's good. Now we know a little bit about Dr. P.
A little bit.
Just a little bit. We'll keep going, but we're gonna go back to the health. We're gonna go back to the health memo. So last slide we kind of left off at we had some birth control questions, a lot of them. So one of the ones we left off at is, for women over 40, what birth control options do they have?
So women over 40, so typically my approach to my patients is like this. Like, I see a lot of patients that come in to me that are on birth control pills or estrogen containing hormone pills, um, like almost into like menopause. Now you can do this. It's not contraindicated, meaning that it's not something that um, you don't necessarily or have to avoid. However, I think is extremely important. Number one, to understand the risk to everything, right? So with estrogen and birth control to have estrogen in it, there is risk to it, right? So there's risk of blood clotting, or thrombotic events. So when I have a patient that is 40, like my question is like, what's your plan? Like, what are we doing here? And if that plan is like, look, I on a short term, I'm trying to get pregnant really soon or what have you, maybe not today, but over the next few months, then something short term like a birth control pill for me is more acceptable. But if you're not either A, not trying to get pregnant for multiple years, or B, not trying to get pregnant at all, I'm all about either progestin only long-term reversible contraception or permanent sterilization. So starting off with long-term reversible IUDs, which are devices that go into the uterus at 3 years, 5 years, 7 years, 10 years. And there's also Nexplanon. Those are the subdermal devices that go under the skin of the arm for 3 years. As well as Depo-Provera, which is the shot. Now, there's so many misconceptions about, these birth control options. There's so much stuff that I hear that's like a lot of garbage. The truth of the matter is a very, very successful forms of birth control. And if you know what you're doing, you don't have problems. Like, the problem that I see is that people will look at the bad outcomes, but they never ask like what happened, right? So a lot of times, like, you'll say IUDs migrate, or they're going to the belly, or they perforated the uterus, or they've done something horrible. Like, you have somebody out there that has horrible stories with IUD. Nobody ever takes a step back and says, who put it in there, right? You can go get an IUD Planned Parenthood. You can go get an IUD at multiple, just places. Somebody could take a 5-minute course and know how to place an IUD. And that doesn't mean they should be doing it. But nobody ever asks who does it. So, for me, I personally have placed thousands of IUDs over these years. I've never once perforated the uterus with an IUD or had an IUD migrate into the abdomen. Me personally, I've never had that happen. But have I had to perform surgery to remove IUDs out of people's bellies? Absolutely, double-digit times, right? But nobody, no one will ever look and see where they got that from. So all my IUD placements and long-term reversible, placements, they do extremely well. But, every, 1 out of 10 may have like abnormal bleeding or pain or cramping. Like, some people may not have a good, good experience with it. And if they don't, just remove it and do something else. But I think it's very, very reliable forms of birth control. Also, permanent sterilization. So we get to this point where you 40 plus, either we're gonna shit or get off the pot. You want to get pregnant or not? If you have absolutely no thoughts of getting pregnant or having a baby, like, you should open up your mind to permanent sterilization. Why play with it? It takes me 5 minutes to sterilize somebody, like literally 5 minutes, and it's very small incisions. You in and out of the hospital. I mean, it's literally an outpatient procedure where I'm taking the tube off, and you will never, ever, 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 ever get pregnant. There's no failure rate. People are like, oh yeah, somebody got permanently sterilized and they got pregnant. That's because somebody didn't know what they were doing. I take tubes completely off. You're gonna get sterilized with me, like, you will never, ever, ever get pregnant again, right? It's never gonna happen. And so if you really don't want to worry about pregnancy ever again, get sterilized. It literally takes 5 minutes. It's no different than a vasectomy. So yeah, that's my approach. Just really trying to find out what you want. If you're really trying to have children, then is this a short-term thing, long-term thing, or what we're trying to do? If it's shorter term, like, really be cautious about taking estrogen replace estrogen containing birth control. If not, if you're really not trying to have children, look at either long-term reversible or look at permanent options.
All right. So piggybacking off of talking about IUDs, we do have a question in the chat box. And they're asking if IUDs are a safe form of birth control, which you kind of already talked about. But their second part to the question was, does having local hormone reduce the incidence of weight gain and bloating?
You said this having, say it again? Sorry.
It says, are IUDs a safe form of birth control, which you kind of addressed already? Yeah. And does having a local hormone reduce the incidence of weight gain and bloating?
I would say yes and yes. And so if my fellas in the chat, if you have a long-term reversible contraception or whatever, feel really, really comfortable, you can shoot up the club. No, let me cool out. Let me cool out. But you can really, really feel comfortable about somebody not getting pregnant whatsoever. So like long-term reversibles are, extremely effective. But as far as the side effect profile, IUDs, absolutely. IUDs release hormones into the uterus, right? So there is minimal systemic spread, meaning that the hormone, yes, it's going to get into your system, but there's not a lot of hormone that's going to get in your system. Most of the way that medication works is that it's a localizing effect inside the uterus. So these the bloating, weight gain, those types of things are much less when you talk about an IUD as opposed to other contraception in which you either take by mouth or are getting into the bloodstream, into the system. But also, too, I want to say this. Let's clear up some misconception. People will do a lot. My alarm setting, overslept it. But people will do a lot of blaming on birth control. Oh, I got fat with this birth control. This is killing me. It's doing it. Let's talk about what birth control does and what it does not do. Okay. All right. So birth control, no matter what form it is, whether it's pills, patch, IUD, what have you, like all of them, if they contain hormone, if they're hormone containing, they either have synthetic estrogen or synthetic progesterone, which we call progestin, right? They're synthetic versions of what our body already produces. They're designed to really trick the brain into believing that the body is doing something that it's not doing, right? That's the premise of birth control. There's not this, people think of hormones, they're thinking of like steroid injected chickens and, it's just now this new hormone or steroids and all. That's not what we're talking about. We're talking about synthetic versions of what our body normally produces. So if you started to take a birth control and you are gaining excessive weight, it has minimal to do with that birth control. It has more to do with you are putting in your mouth, right? Because if you keep the same diet, same activity level, you typically will not gain weight. And that even goes for Depo-Provera. And Depo-Provera, a lot of people gain weight. And this is a fact. It is true that women gain weight with the shot. Why is that? It's not because it's the actual shot. It's because the shot in of itself increases a hormone called ghrelin. Ghrelin in the body controls hunger, right? You take the shot, you get hungry, you eat more, and thus you gain more weight. If you take the shot, you get hungry, realize that you're really not hungry. It's more so because of the shot. You keep your same diet and activity level, and you don't gain weight. So I talk to patients about this all the time, about, watching your cravings, watching how you eat when you have birth control. But it's in specific answers to the question as far as the side effect profile, yes, you can have some bloating. You can't have some minimal weight gain. IUDs do have a lower side effect profile because that hormone is not disseminated throughout the system. It is more localized in the uterus. So I highly endorse IUDs for people that have had issues with systemic effect for birth control in the past.
All right. And last IUD question on the list tonight. Does the copper IUD deplete, well, on the list right now, does the copper IUD deplete your body of zinc or any other vitamins?
No, short and sweet. Absolutely not. It does not. The copper in of itself is designed to create a hostile environment of the uterus. What do I mean by that? It basically causes a local irritation of the uterus to make it produce more mucus and to make it much more difficult for the transportation of sperm to get through the uterus and through the fallopian tubes. That's what I mean by hostile environment. It's not secreting any hormone, but it's causing an environment that is not welcoming to sperm. It makes it difficult not only for sperm to get up, but for a fertilized egg to come back down and implant into the uterus. That's how it works. It's not depleting your body of anything. It is just made of copper because that's what they found will create this effect in the uterine cavity, but it does not deplete your body of any hormones or mess with anything like that. No.
All right. Next question. How do you stop your period for a couple of days? Or can you do anything to bring it earlier if you need it to be off or on by a certain time?
Good question. So there's multiple things that could be done. Typically, they have to do with, hormone suppression. So just really quick, your uterus, the uterine lining is controlled, is really based off of estrogen, progesterone. So estrogen increases the thickness of the uterine lining or the endometrium. Progestins basically bind it so to strengthen it. At the end of the month, all that stuff kind of trickles down. The progestin gets low, estrogen gets weak, it breaks off and sloughs off. When a patient comes to me or a friend, family, whatever, they want to just stop their period for whatever, be a trip or a honeymoon or what have you, progestins, right? So progestin or synthetic progesterone can be given to strengthen the lining of the uterine cavity, and basically it will, suppress periods from coming. And if someone is taking birth control pills, you can continue the birth control pills throughout the placebo week and basically strengthen that lining and keep it going on. Now you got to be careful because if you continue to do that, you can cause a problem. So you need to have a period at some point if you're taking an estrogen containing birth control. So don't try to do it yourself. Don't try to, I'm gonna take a couple of birth control pills and then I'm gonna, tinker with my period. Don't do it yourself. Go with a professional that knows what they're doing to assist you with that. But yes, you can suppress your period. But there's also non-hormonal methods that we really don't talk about that will suppress your period. So there are menstrual cups in various forms that can be very functional, can be placed, that you can still have sex with, that you can still do a lot of stuff with that will catch the bleeding, and you can discard of it. So I have many patients that utilize menstrual cups and are very, very happy with it and swear by it. So that's a non-hormonal way to also control your bleeding if you're at a time where you can't afford to have bleeding, if you will.
All right. This is a question in our chat. What is the purpose of a hysteroscopic myomectomy? Okay,
hysteroscopic myomectomy. I got it. What's the purpose?
So
and
can it cure infertility?
All right, that's a tough question. All right, well, that's a two-part question. So hysteroscopic myomectomy is based anytime you have the word scopic or OPIC, opic, on anything, whether it be laparoscopic, endoscopic, colonoscopic, hysteroscopic, laparoscopic. I mean, anything with scopic at the end means scope, means you are looking into something, right? So in the case of hysteroscopic, meaning you're taking a camera and you're looking into the uterine cavity, because hyster means uterus. So putting a camera into the cavity of the uterus. A hysteroscopic myomectomy is when there are fibroids that are actually what we call submucosal, and they're pushing into the cavity of the uterus. When you have those are the most problematic. So we worry about fibroids in for two different issues. Number one, size. Abnormally large fibroids can cause problems, but two, location. So fibroids that are pushing into the cavity of the uterus cause a problem. A hysteroscopic myomectomy is actually taking a camera and removing the fibroid that is in the uterus. Now, the problem is very rarely is a fibroid just solely submucosal or pushing into the cavity. It can have a component where it's pushing into the cavity, but can also have a component where it's still in the muscle. So you can get hysteroscopic and scrape the part that's in the cavity, but you can also still have a significant part that's still in the muscle. And if you have that happen, you still have to address the part that's in the muscle. So with the hysteroscopic myomectomy, yes, it really depends on how much the fibroid is pushing into the cavity, what you're trying to accomplish. I have patients right now. Actually, I have a patient that's from out of town that's having the issue of a submucosal fibroid that's pushing into her cavity. She doesn't have symptoms, but she's having the problem with her fertility clinic, and they're not wanting to do an in vitro fertilization cycle because of this fibroid pushing into the cavity. She had a doctor that went and did a hysteroscopic myomectomy, and lo and behold, a few months later, she still has fibroid into the cavity. The reason being is because even though they got the fibroid the part of the fibroid that's in the cavity, they never addressed the part of the fibroid that's in the muscle. So they got that part out. Over time, it just started to herniate. The rest of the fibroid just starts to herniate back into the cavity. So answer to that question, hysteroscopic myomectomy is very useful. But if you have a large fibroid that still has a part that is in the muscle, you still need to address, typically, you need to address that part. Now, for women that are having infertility, you got to be very careful. If you're having infertility, fibroids may be a significant part or hindrance in your fertility. However, it may not be the only part, right? There may be multiple things that could be true at the same time. You can have submucosal fibroids. You can have poor egg quality. You can have blockage of your fallopian tubes. You can have a low sperm count. You can have a multitude of different things, but you can't just pinpoint focus on, oh, I got fibroids, that's why I might get pregnant. Focus fibroids. But you have to use a very like panoramic view of what's happening, right? It has to be looking at all aspects, looking at the man, the woman, looking at the hormone levels, looking at all different things when you're looking at infertility.
All right. This is a question that was submitted. I shadowed an abortion at 6 months done for a woman with preeclampsia while I was in Ethiopia. Do you think they chose to terminate because of lack of resources, or is that necessary? What are your thoughts on dealing with preeclampsia?
So they had preeclampsia, and what happened?
They gave them an abortion at 6 months. They made a choice to terminate. She said she was in Ethiopia though.
At 6 months? That's tough. I think that is a region specific thing. I can't speak on like Ethiopia, but it's 6 months. So 6 months is a 24-week gestation. Like at 24 weeks, that is the first week of viability, meaning that if anything happens, you can actually, if something happens bad in that pregnancy, you could do life-saving interventions to try to save a baby. So can you go into preeclampsia that early? Yes, you can. It's rare, but you can do that. It can happen. I've experienced that. But at 24 weeks, if you're doing that, you're not terminating that pregnancy. If you had to deliver, you would give steroids to try to mature the fetal lungs, and then try to get as much time as possible, and then actually deliver that baby and give it a chance at life at 6 months. Now, if it was, before then, which is, you don't really see that preeclampsia wise, you wouldn't do that per se. I've never had a instance where you've had early preeclampsia to that point where you had to terminate a child. Usually patient will have, chronic hypertension, but you know that before 20 weeks. That's how you know when a person has chronic hypertension as opposed to, gestational hypertension or preeclampsia, because if it happens before 20 weeks, that means the person already had it. If it happens after 20 weeks, that means it's something related to the pregnancy. But by the time you get to 24 weeks, there's things that we do.
You can talk to me anytime.
There's things that we can do that will intervene and to save that child.
All right. Switching back to the chat box. What is the best way to lose weight slowly?
Awesome. So losing weight is, you have to really analyze what your diet is, and I can get into very, very detailed stuff, but in a nut and bolts fashion, it's about what your intake is and what your energy expenditure is. So I'll give my analogy like really quick and cut it down because I can get really, really extensive with it. But if you have to look at your intake, and as far as like caloric intake. So for instance, if you eating, let's say 1,600 calories a day, right? And then you're burning 2,000 calories a day, meaning that you're utilizing with your energy expenditure 2,000 calories, and you're only taking in 1,600 calories. You have a deficit of 400 calories for the day. If you do that every day, Monday, Tuesday, Wednesday, Thursday, Friday, you have 2,000 calorie deficit for the week. You add in Saturday, Sunday, now you got 2,800 calorie deficit for the week. If you now add in aerobic exercise for 3 or 4 of those days, now you can add another 1,200 calories. If you do 400 times 3 days, now you got another 1,200 calories. That's 4,000 calories of deficit that you have a week. You have to lose weight. You have to. You cannot continue to put on pounds. You have to look at your body like like a car, right? If I put a full tank of gas in my car, you can only drive as much as that tank of gas is going to give you, right? And then your car is going to shut off. The difference with the body is that we have stored gas tanks. What is that? Fat, right? So after you've utilized all of your energy stores per day, now your body has to start chewing what it normally has. You cannot build fat if you have a energy expenditure. If you have a total deficit every single week, you have to lose weight. So it comes down to a calculation of your weight, your height, age, and then looking at specifically the body, the food that you're putting into your body. Foods that are high in caloric intake, you want to decrease those. So decreasing carbohydrate intake, like your breads, rice, pastas, potatoes, decreasing those, increasing your high protein in your diet. And this goes for everything. This goes for all of the processed stuff you put in your that we're eating. This goes to you drinking coffee, you putting sugar in it. You drinking sodas and juices instead of water. Like there are so many things that we add to our diet that put on calories. Like I know people, you drink 2 or 3 sodas a day, or you drink, your Starbucks in the morning, you've already added, 500, sometimes 1,000 calories to your daily intake already. And I went to the gym ain't a cure-all. Like the gym is good, but your diet is 80% of that. So I would say, analyze everything in your kitchen and look at the caloric intake. Like I could break all that stuff down, but we could be talking about that for days. But in a nutshell, more calories that you burn as opposed to the ones that you put in. And if you do that over time, you can lose. I tell my patients all the time, to be realistic, you can lose a pound a week, a little bit over a pound, pound and a half a week. That's 5 pounds a month. You got a big weight loss goal. Like if you lose 5 pounds a month, in 6 months, that's 30 pounds. In a year, that's 60 pounds, right? That's how you do it. You're looking at it week by week, how to lose a pound a week. And you can accomplish any goal you want to. And it's really not that hard. It starts in the kitchen. There's absolutely nothing healthy in the streets. I say this: if you have left your house and you don't have your food, you have failed for the day. All right, whatever you're gonna get in the street, whatever you're gonna order, DoorDash, Uber Eats, drive through, whatever, it already is bad. Right. So if you want to accomplish that, you have to put the time into the kitchen. Me, as much as I work and as much as I don't play around with my food. Like anybody knows me, I'm not eating out. I don't eat out like that. I don't buy food here and there, very, very sparingly. But I take my time and I meal prep. I have food. I have Tupperware dishes. Like, I've been in this hospital for 7 years, and I've been to the cafeteria here maybe 3 or 4 times. I've ordered food maybe 3 or 4 times. I don't do it. I always have my food no matter what.
I could personally attest to eating habits is the biggest thing. I lost a lot of weight, and it was 180% what I ate. Definitely. Absolutely. I agree. The best investment is a food scale, because I promise you, what you think is a portion is not a portion. So waist trainers, flat tummy teas, buy a $5, $7 food scale from Amazon, and you already halfway there, and you know exactly how much you're eating.
Man, people with all of these flat tummy teas and all these teas and all these gimmicks and stuff with it, it's like, stop it, man. Save y'all money. Save y'all money. Y'all wasting y'all money. Just eat right. Just eat healthy. If you need somebody to show you how to eat that, like eat healthy, holler at me or holler at somebody like a fitness expert that understands nutrition. But y'all spending all y'all money on these get slim quick theories and teas and pills and stuff. It is a waste of money and time, just like fibroid pills. Like, it's people harp on your ignorance, your insecurities, and your fears. That's how people get paid, right? When you have something with either people don't know about or they're really, really scared about it, insecure about, that is a way to make money off of it. If I put a name, or if I put something where they're scared and they can fix it, or you can fix it, then I can make money off of you, right? People are scared shitless about fibroids or what have you. So if I say I got this tea that you could take to shrink your fibroids, you're going to buy it. Or, if I got, this pill that you could take that's going to burn your fibroids. Like, just think about it. Like, how does it do that? Who went in their little basement and concocted up this magical serum that we don't know nothing about, that is going to automatically do this stuff, and that you're paying $40 for to make it work? They've taken your money.
$39.95.
Oh my God, man! If I had $1, people coming in. Do these work? No, they don't work. They don't work. Give me your money. Just give me your money, because you just, you want to give it away. Just give it to me. I need it. My kids need it. Just give it away if you're gonna give it. Good Jesus.
Absolutely. All right, moving right along. All right, I had a prolapsed uterus with huge fibroids and endometriosis, so I had a partial hysterectomy. I recently went to the gynae due to pain in my ovaries and found out I have endometriosis again. How is that? It's even visible on my clitoris. How is that even? Does that even happen? I had a hysterectomy due to this issue.
That's a first. Endometriosis on the clitoris. I had to see that one, actually. But as far as endometriosis is concerned, just from an educational standpoint, endometriosis is implants of the lining of the uterus that are not in the lining of the uterus. They are in like the belly or the peritoneal lining. They could be on your ovaries. They could be on your bowels. They could be like all throughout the lining of your abdomen, right? That's what endometriosis is. And it's problematic because the ovaries produce hormones that fuel endometriosis. All right. So as long as you have ovaries that produce hormones, you're going to have the fuel for endometriosis. So that person's doctor really did not explain this well, because just doing a hysterectomy for endometriosis is doing the person a disservice, because you still have ovaries that are going to produce hormones that can cause problems. With that being said, the key to endometriosis is actually cutting off the hormone source for the hormones, before the endometriotic lesions to feed on. So either A, you do hormone suppressants or, medications to basically stop the hormone from producing, or B, you can go in and do surgical removal or burning of the lesions and then give medications to cut off the ovaries or cut off the supply of hormones from the ovary. Or C, last but not least, I've had patients that have horrible endometriosis. They failed surgeries, they failed hormone suppression or medical management. Then those patients actually need their ovaries removed. That is extreme cases. Have I had to do that for some patients? Yes. But typically, 90% of the time, you can do hormone suppression or surgeries that will not sterilize a woman or will not take, their ovaries out. But the answer to that woman's question, she still has her ovaries, so her ovaries are producing hormones. The endometriosis does not go away with a hysterectomy. You still have the ovaries that are there. So either A, so I have to get on medication to suppress her ovaries, which what I would suggest first, or B, removing the ovaries. And if you remove the ovaries, that does have consequences to it. So don't just think removing the ovaries and that's it. Like ovaries are, responsible for our heart health, bone health, and a lot of other different important things. So, you got to be real cautious before you just say, just remove the ovaries, because that could be, very problematic, especially for younger patients. The younger you are, the more problematic that removing the ovaries can be. You decrease life expectancy. You increase the risk for heart disease. You increase the risk for osteoporosis or bone disease. So you got to be real, real cautious about a doctor just telling you, just take the ovaries out like you 30-something years old. Like there are other treatments and other things you need to do. Taking your ovaries out is a last-ditch, last-step effort. And if you do have your ovaries out at this very young age, you need hormone replacement in a low dose to take the place of, that estrogen component that you're missing.
All right. If you just join in, please drop your comments or questions in the comment box. At the bottom of the chat, you'll see a question box with a question mark. Instagram, like so I don't always see the comments on the screen, but if you put it in that chat box, it'll make sure that I see it, and it'll also make sure that if I don't get to answer it this time, we roll it over to next month. So I'm going back between submitted ones and the ones on the screen if you put it in the chat box. All right, next up, this is a sexual health question. I have been celibate, but I recently purchased a toy that I have been using externally for stimulation. No insertion is needed. However, I recently noticed that the following day, I may see light blood when I wipe. It's odd because I never really experienced post-coital bleeding.
Post-coital bleeding.
Okay. Is this a sign of a deeper issue, or should I just throw the thing away?
So first, she talking about that rose, the rose. But nah, you don't have to throw it away. Self-stimulation, masturbation for women is, is awesome. Like, you should stimulate yourself. I implore that. Some of the misconceptions about, masturbation for women is that you can desensitize yourself and make it so that it's impossible to have orgasm, which is totally false. Same way it's false for men. Masturbation for women and understanding your body and understanding what you like and how to orgasm is extremely important. I implore it. As far as, post-coital bleeding, which means bleeding after intercourse, which can come during masturbation, or it can come from sexual partner. It's bad. It happens. Usually, post-coital bleeding, you don't hear as much. It's just clitoral stimulation. Coital bleeding typically happens with condition or intercourse, and usually it is from like cervical trauma. Like I did a point this a while ago. It's from
I think your earpiece, you breaking up.
This is the worst iPhone I had. I'm still breaking up.
You clear now.
It's clear. All right. So post-coital bleeding is like when the penis really irritates the cervix, and it can cause some irritations of the cervix and can cause bleeding. That's typically what happens. It's called what, beating the cervix up or beating it up, literally. And you can have, bleeding from that. That's usually what it's called. However, it can be an indication of cervical dysplasia or, some type of, cancers of sort. So it is very, very important that you, follow up with your gynecologist, making regular visits or have you, to have somebody that understands what's going on anatomy-wise and to look at your cervix, look at your vulva, look at your vagina, and make sure there are no sores or lesions or questionable things that are happening, or looking at hormone levels, looking to make sure that you're okay from that perspective, because bleeding or postcoital bleeding can be an indication that there's a problem, but typically it's not a problem. But with that being said, I'll say don't stop using your rolls, continue to use your rolls, but also to make an appointment with your gynecologist to get your yearly exams, your annual exams, and even just your checkups to make sure that everything is okay and to make sure that the postcoital bleeding is nothing to worry about.
All right, a question in the chat. What is a LEEP, LEEP procedure, and does it cause infertility issues?
Excellent question. So a LEEP procedure stands for loop electrocautery excisional procedure, right? And it is for women with cervical dysplasia, meaning that the reason why we go and get pap smears is because we're giving cervical exam. We're testing cells of the cervix to see if a woman has, one, high risk HPV, and two, if the high risk HPV is causing abnormalities in the cells of the cervix. When a woman has very abnormal or dysplastic cells of the cervix, the next step would be to do a colposcopy to kind of diagnose it, which is a biopsy, looking at the cervix under a microscope of biopsy. If it's advanced level dysplasia or abnormalities, a LEEP procedure is taking a cautery device and basically lancing off the very tip of the cervix. And that is done to remove the abnormal part of the cervix and to decrease the risk of cancer or prevent a cancer from happening. As far as can infertility happen? No, typically not, unless somebody is really not skilled and doesn't understand how to use the LEEP device or the electrocautery device. It can increase the risk of cervical incompetency, right? Which is when the cervix is not able to withhold the pregnancy and dilates early. That does increase the incidence of it. LEEP does, but you don't find many instances in which it's causing infertility. Infertility would be when you do it and then it completely blocks off the passageway or occludes the cervix to where sperm cannot pass out or pass through the cervix into the vagina. Into the vagina and through the cervix into the uterus. That typically doesn't happen, because if it's going to cause infertility, it'll cause a whole bunch of other different problems, i.e. occlusion to where blood can't come out, a cervical stenosis to where blood can't now come out, and there's a bigger issue. So I have not seen a LEEP procedure causing infertility per se, but it can cause some complications in pregnancies, typically not, but it can increase the risk of complications like cervical incompetency in pregnancy.
All right, this is a guy follower.
Yay!
If a man finds out he has prostate cancer, can he still have an erection?
He most certainly can. He most certainly can have an erection. Cancer does not prohibit him from having an erection. However, there are, if he needs a prostate removal or prostatectomy, anytime you hear ectomy means removal of something. So prostatectomy is basically just removing the prostate. That can cause issues with some of the nerve innervations that can cause impotence or erectile dysfunction. So you have to be careful with those surgeries. but it can increase the risk of that. But just the diagnosis of prostate cancer does not mean that you cannot get an erection anymore. You may have problems if the prostate becomes enlarged or hypertrophic prostate. Like it can cause an issue if it gets overly enlarged with erection, but typically those men still have erection. Just may be a little bit more difficult to do so.
All right. Is it true menopause will dissolve your fibroids?
No, that is not true. Menopause is when the ovaries start to fail. I mean, the ovaries are now not producing hormones, not ovulating any longer. Fibroids, it is true. Fibroids are fed by hormones, right? So they get larger because they are recipients of hormones. The ovaries stop producing hormones. Fibroids should not grow anymore. That doesn't mean that they just dissolve, shrink, and poof into dust after. So you can have some reduction or shrinkage of fibroids, but they're not going to go away per se. And especially if you have very large fibroids, like 8, 9, 10 centimeter fibroids, they're not just going to go away because the ovaries stop producing hormones. They're just going to be there. They're just not going to get any bigger. With that being said, if they're not giving you any problems, no issues, no matter how big they are, you don't necessarily have to do anything about them. And menopause also helps to where they're not going to grow anymore. So if they're not bothering you, you don't have to do anything. So now I have patients that are 65, 66, and on exam, I feel fibroids, but they're not having problems, not having issues. They're living with them perfectly fine. I don't have to do any surgeries on them, but they're not necessarily going away or, vanishing because you go into menopause.
All right. And so segueing into that, we have another question in the chat. Can we discuss premenopause and if there's anything women can do to prepare for it? Examples, specific vitamins.
No, in answer to that. So women kind of, I understand I never wanted to be insensitive about menopause and women going into menopause because I deal with it every day. But realize that, in difference from a man doesn't have this issue, right? So we continue to produce sperm. Sperm production only happens, till the day we die. As far as women are concerned, once you first start to have your period, you are already in premenopause. All right, just think about it that way. There is an expiration of your ovaries, whether, you're close to that expiration or not. You're living and that expiration date is going to happen. So if that is being said, you're automatically in premenopause per se. No matter how old you are, any reproductive age, you're inching towards menopause. Now, I have a lot of women that come in and 44, 45, 46, 47 years old that are having abnormal periods, are really freaked out about menopause coming or whatever, and want to give every want to give every lab under the sun to find out if they are entering menopause or in menopause. And my answer to them is, you are. It is, no matter what, if you're that age, you're entering that. At some point, your ovaries are going to fail. So really getting all of these labs to tell you something that you already know doesn't necessarily make much sense. But as far as prolonging your ovarian life, yes, taking daily vitamins are important for your overall general health. And I'm a firm believer that, living a healthy life does equate for healthiness of everything, right? So you can't expect to be unhealthy in your daily life and expect to have long fertility and long ovarian life. So you have to be very cognizant about your diet, about your exercise, about your activity level, what you're putting in your body. These things are going to pay huge dividends in, what your life of your ovaries are going to be. So I wouldn't necessarily say there are any vitamins or anything per se, but it's lifestyle, right? It's how you live your life, how you eat, how you work out, how you do these things, right? That's going to give you the longevity of your ovaries. But don't freak out, right, about going into menopause. It's going to happen. And And I know that sounds insensitive, but it is. And just understanding what your body is going through and understanding how to manage that is key. And just educating yourself to what's happening in your body should alleviate a lot of fears about it.
All right. Trying to watch the clock, so I think we got time for one more. This one is actually a good one. It says, let's address the elephant in the room. Cola or DocP. Let's be honest. People keep asking about hormones, but what we really want to know is, will you be dry after you have a hysterectomy? What's the truth?
You can answer that one.
All right. So I wasn't having sex in my uterus. I was having sex in my vagina. So whatever vagina you went into surgery with, you will return, because they do not take your vagina. They take your uterus. The uterus just snitches on you if you've been having sex and you get pregnant. That's how you know that you was doing that. But I promise you, you have sex in your vagina. And I'm not even a doctor. I promise. So whatever vagina you went into surgery with is the one you'll return with if you have a good doctor.
And so, in specifics to that, as far as the dryness and stuff are concerned with the hysterectomy, I say all the time, you have to be very careful with these terms, these partials, completes, and all that stuff. They're really just bad terminology, and I hate it. All right, hysterectomy is a hysterectomy, right? Complete, partial, all that stuff is just bad terminology. If you are taking out the uterus, that is a hysterectomy. There's really no such thing as a partial and complete. There's a total and a subtotal. So a total hysterectomy means removing the uterus and the cervix. A subtotal hysterectomy or supracervical hysterectomy means removing the uterus and keeping the cervix. Notice I said nothing about the ovaries. So if you say partial hysterectomy, that does not mean anything to do with the ovaries. Complete hysterectomy does not mean have anything to do with the ovaries. Removing or keeping the ovaries is a separate part of the procedure. If you keep your ovaries, which any woman, like Holy Red, right, young, vibrant, ovaries are still producing hormones, you keep your ovaries. So with that being said, if you keep your ovaries, they're still going to produce hormones. You should not have any problems with vaginal lubrication or menopausal type symptoms, right? So no, you're not going to have vaginal dryness because you have ovaries, because if you have a hysterectomy, because you still have ovaries. If you get your ovaries removed with the hysterectomy, then yes, it's possible that you can't have vaginal dryness. The reason being is because the ovaries produce hormone. Now, notice I say that's possible. Every woman that goes through menopause does not experience the same symptoms. Some women that go through menopause don't have any problems. They don't have any hot flashes. They don't have any vaginal dryness. They have sex regular, no problems, no issues, no concerns. God bless, kudos to them. They're in a minority, but there are women out there that go through menopause with no issues whatsoever. A majority of my patients that go through menopause will have an occasional hot flash, may have a little bit of vaginal dryness, but they can use lubricants and things to counteract that. Don't really have major problems from menopause. A small minority of my patients live miserable lives. They can't function because they have the hot flashes. They have vaginal dryness, pain with sex because of their ovaries. Those patients need to have that addressed and may possibly need medications for it. When you remove the ovaries with a hysterectomy, it is essentially putting a patient into menopause. How they will react after that, again, is variable. Some women won't have an issue. A lot of women will. But you need to be very specific about age, and when you perform a hysterectomy, are the ovaries being removed? Because it really is not a hysterectomy or complete or partial or any of that stuff. Hysterectomy is removing your uterus. Actually removing your ovaries is a separate conversation that your doctor should have with you, and telling you what the risk and the benefit of removing the ovaries actually is.
Absolutely. And somebody followed up and said, did I have my ovaries removed? And Dr. Johnson is correct. No, I did not. He already told my age last time. I'm 42 years old. So
hey, we're the
we
same
had
age,
that
so it's all
conversation.
good.
we had that conversation, like he said, about whether they were healthy or not. So we made the decision that that was not necessary in my situation. So, all right. Well, we at like 5 minutes, so I'm not gonna stretch
That's
it because
fine.
Instagram already be acting a fool. But as always, we definitely appreciate you. So I think I got to everything that was in the question bubble tonight. There are some of you that DM me directly, so I promise I will roll your questions over because some of you send them while I'm on the live. I'm trying to do multiple things, but I got you. And we definitely gonna keep it going because people keep asking for it. And Dr. P is gonna put it on his page. I will also upload it to YouTube. You can share with a friend who doesn't have social media. And one day, maybe Dr. P will let me be in a Tesla. Y'all should put car emojis on the comments because
You
I
got it. We'll do
still,
it. We'll do it. We'll do it from the Tesla one day.
yeah, we need to do a live Tesla Chronicle. So if y'all watch this video on his page after, because he gonna post it, put a car emoji in the comment if you think we should do a Tesla live.
I'm down with it.
So I could play a
that
couple
sounds
of
like a plan.
so I could get the aux.
and y'all for real, like, man, like, seriously, like, it, I hear people ask these questions like all the time, what have you. Like, I do these lives, they are free. This is free game, free information. Like, share this stuff, please. Like, it's like I never want anything for educating folks because I honestly believe education is our key to eradicating disparities, which is why I do this. But if it's only a few people that are actually benefiting from this, like, it kills me. Like, I really, and I'm not trying to get viral or like go viral or get any clout or what have you, but more so about like people actually getting the information, because I see all of these groups and blogs and people doing all of this stuff where there's so much misinformation that is being disseminated out here. But when you have like actual valuable information for people, yeah, I'm not a TikTok guru. I'm not about to sit up here and do dancing and moonwalking to try to get y'all information or what have you. But I'm gonna tell you the real. And so, people always want to really like nobody talks to us and nobody, gives the information, like people, doctors of mine or whatever. But when they actually are doing it, you don't want to listen because it's not entertaining per se. It's like, man, I try to entertain y'all a little bit, but at a certain point, like I'm like, fuck it. Like, I can't, like I cannot, like I can't keep up. I'm just not creative enough.
Yeah, tell your age.
No. No, I'm 40. Yeah, I'm 41. Like, I had to have my kids, help me with TikTok too. I ain't ashamed to admit it. But I'm just saying, like, I just, like, for real, like, share this stuff. Like, people should really, really get this information. And have them join the lives. Like, it's free game and free information for us to really know more about our bodies and to live healthier lives. That's really what it's all about. So, don't just keep the information for yourself. Share it, invite people to come in. This is like, this is a no risk, safe zone for people to really get information and really ask questions and learn about stuff.
And that's another reason why we don't mention names. We just say the question. We protect our privacy. So it's a very safe space. Something you may not have been, brave enough. We're here. So I definitely appreciate it. And I definitely appreciate, who knew me taking care of such an issue was going to turn into all of this. I say it every time. So I appreciate it.
Y'all can scroll back. She came all in the office nervous, like,
very nervous,
extremely
scared.
She's like,
I was extremely
butterfly.
The day of surgery, I asked him, could I change my mind? Like, it was. I had gown on and everything. He was like, no, we doing this.
Yeah, we doing this. And so she done came all the way out of the cocoon, butterfly blossoming. Like, this is beautiful. Like, this is why I do it. Like, stuff like this is like really, what makes it all worth it for me. I mean, because like I said, it ain't about the money for me. Like, I promise you, I look at it sometimes with like some of this stuff and like, really, why are you doing this? And it has nothing to do with money. It's more so to do with actual like health and helping people and seeing people like change their lives. Like, that does it for me. Like, I want to see people do well and really live healthier lives, and that's why I do it.
I have literally went more places in 6 months than I went probably in 6 years. So I
Dope.
definitely, it does make a huge difference. I don't even know why I thought the before was tolerable. I don't even know why I thought that.
So them 6 hours I was up in there fighting with that big monster you had in your belly, every second was worth it.
It
For you
really
to be able to do that is all worth it for me. And hey man, people don't understand, like I was in there battling and struggling, but all of that is worth it. Like it was so very worth it to have you, be where you at right now. That pleases me immensely.
And I'm happy that it's making other people brave enough, because I definitely get feedback where people say, because of your story, I did something about it. It may not even be fibroids, but they did something that was going on with them health wise that they didn't have enough courage. So,
and I told you that I have people come to me all the time, be like, I saw her story, and I got like, I'm like, yes, because y'all don't want to listen to me. Like that's fine. I don't care. That's what I let people that I've helped like be able to tell their story, because like if you don't listen to me because I'm a man and you think I don't understand or whatever, that's fine. But listen to people who have actually been through it. And your story is a testament to like how life-changing things can be once you address the actual issue and actually put your trust into somebody that is going to give you the care that you deserve. So do your research, everybody.
Yeah, because I never didn't get scared, but I did trust you, and that made a difference. Yeah.
Oh.
All right. Well, I appreciate you, Doc. You are always a true gem to the city. So
thank you.
I will see you next month.
Next month, same bad time, same bad channel.
And we're gonna do 7:30.
Yeah, like I was just bad because I was in Phoenix. I had to fly to Phoenix yesterday. I came in late last night. I had surgery this morning, so it was just like sometimes it just hit me and be like, "Nigga, go to sleep." Like you got to
listen to your body. Do you just say you're a health nut? Listen
Absolutely.
to your body.
Man, my body was like, I was sitting up here looking at emails or whatever. It was like, go to sleep, my child. And that's what I did. I took myself over there and just took a little nap. So I had to.
Well, good job.
All right.
Go back to it.
All right, y'all.
All right. Thanks,
good
everybody.
Night, everybody. All right. Talk to y'all next month.
Bye-bye.